I am Dr. Sarita, Professor of Anatomy. I will be discussing the development of placenta in detail. Placenta is a vital organ. All eutherian mammals possess placenta. Placenta is highly vascular structure. It's attached to the uterine wall and establishes connection between the mother and the fetus via the umbilical cord. Placenta in Latin means flat cake. In mammals, developed during the pregnancy. Therefore, it is known as feto-maternal organ. Human placenta is a primary site of nutrients and gaseous exchange between the developing fetus in the intrauterine life and the mother. Development of placenta begins during implantation of the blastocyst as beginning as the second week of intrauterine life. Placenta is formed gradually during the first 3 months of pregnancy. After fifth month onwards, it grows parallel to the development of uterus. Placenta develops as the blastocyst implants into the uterine endometrium, that is around the 7th day or the end of first week of development. During the second and third week, it develops considerably, and later on, from 20th to 40 weeks, it grows parallel to the development of the uterus. Therefore, placenta is a feto-maternal organ that facilitates between the maternal and fetal compartments. Human placenta is discoid, hemochorial, Hemochorial means the chorionic frondosome, which is derived from the fetal tissues, which is directly in contact with the maternal blood, and decidua, which also connects the fetus with the uterine wall of the mother. So human placenta is defined as discoid, hemochorial, and deciduate. Placenta exhibits two surfaces: maternal surface and fetal surface, that come in direct contact without rejection, suggesting immunological acceptance. Shortly after the birth of the fetus, placenta and fetal membranes are expelled from the uterus. Coming to the development of human placenta, which has two important sources. The fetal part is chorionic frondosome, the tertiary villi at the embryonic pole. Maternal part is a uterine endometrium, that is the decidua basalis. At the embryonic pole, villi at the embryonic pole is well developed and bushy, and it is known as chorionic frondosome. Villi at the ab-embryonic pole is chorionic villi, less developed, later degenerates by the end of third month or 12 weeks of intrauterine life. Coming to the stages of development of placenta. Trophoblast is the fetal part, Deciduous basalis is a maternal part. Development of placenta starts at the end of first week at the time of implantation of the blastocyst, and it is almost completed by the 12th week of development. Placental development is therefore begins at the time of implantation, that is implantation of blastocyst, which occurs at the end of first week of development around 6th to 7th day of intrauterine life, and it is completed by the 12th week or the 3rd month of intrauterine life. The blastocyst consists of two important groups of cells, the embryoblast cells or the inner cell mass, which forms the embryo proper, the outer cell mass, which is known as the trophoblast, which later forms the placenta and associated fetal membranes. So coming to the development of the placenta by the end of first week. Blastocyst with inner cell mass, that is embryoblastic cells, which is yellow in color, and outer cell mass, which is blue in color, is embedded into the endometrium, and this is the implantation which occurs at the end of first week of development. Endometrium is known as deciduous after the implantation of the blastocyst. Deciduous covering the embryonic pole of blastocyst is deciduous basalis. At embryonic pole, it is deciduous capsularis. The rest of uterine cavity lining is known as the deciduous parietalis. Second week of development of placenta. The trophoblast, which is the outer cell mass, is characterized by two layers. Multi-layer syncytial trophoblast with no clear cell membranes penetrate into the deciduous basalis. The inner layer is mononuclear cytotrophoblast, is lined internally by extraembryonic mesoderm or the primary mesoderm. Lacunae appear in the syncytial trophoblast, surrounds the entire chorionic wall, more so at the deciduous basalis. These lacunae erode the branches of the uterine arteries and veins and establish connection, and this connection is known as uteroplacental circulation. So at the 9th to 10th day, uteroplacental circulation is established in the blastocyst. So coming to the overall view of trophoblastic cells, blastocyst implanted occurs at the first week of intrauterine life, and later the outer cell mass differentiates at the beginning of second week into cytotrophoblastic cells, mononuclear, and syncytial trophoblast cells, which is multinuclear. Syncytial trophoblast erodes the maternal blood vessels. Initially, it erodes the sinusoids or the venous system. Later, it erodes the uterine arteries, establishing uteroplacental circulation, which is established around 10th to 12th day of intrauterine life. Changes in the trophoblast occur during the third week. So the important changes are formation of villi. Villi formation occurs at the end of second week and it is completed by the third week. So at the beginning, we start with the formation of primary villi, that is the cytotrophoblast penetrates into the syncytial trophoblast at the end of second week. Cytotrophoblast penetrating into the syncytial trophoblast. This is the primary villi. Later, the extraembryonic mesoderm penetrates into the cytotrophoblast, which is overlapped by the syncytial trophoblast. And this is a secondary villi. and secondary villi are formed at the beginning of the third week of intrauterine life. Finally, it is the tertiary villi formation. So, in the extraembryonic mesoterm, blood vessels appear, that is, the arterioles and venules and capillaries develop, and tertiary villi becomes a vascular structure. And tertiary villi develops at the end of third week of intrauterine life, that is around 20th to 21st day of intrauterine life. Tertiary villi are vascular villi. Later on, the cytotrophoblastic cells in the villi penetrate into the endometrium, and later they reach the and they also establish connections with the similar extensions of the neighboring villus system, forming an outer cytotrophoblastic cell. The outer cytotrophoblastic cell binds the embryo or fetus firmly with the developing placenta via the umbilical cord. Villi extends from the chorionic plate to the decidual plate, and these villi are known as stem villi or anchoring villi. Those that branch from the sides of the stem villi are floating villi or the terminal villi. It is in this terminal villi, which is bathed with the maternal blood, the exchange of substances or nutrients and gases occurred. Tertiary villi therefore gives rise to numerous floating villi, which is bathed in the intervillous spaces, which is filled with maternal blood. And this intervillous spaces, they appear as a labyrinthine structures. Now coming to the important connections of the capillary system. The capillary system or the maternal blood vascular system communicates with the capillary system in the intervillous spaces, which is bathed with anchoring villi and its branches the floating villi. These villi, the anchoring villi, they further come in contact with the capillaries present in the chorionic plate. Capillaries in the chorionic plate finally communicates with the blood vessels in the connecting stalk, which is now known as umbilical cord. Capillaries in the umbilical cord establish connection with the intraembryonic blood vascular system, which is simultaneously appearing or developing in the embryo. Intraembryonic blood vascular system develops 1 to 2 days later than the extraembryonic blood vascular system. Finally, to conclude that extraembryonic blood vascular system is first formed, which later communicates with the intraembryonic blood vascular system and finally with the primordial heart by the end of third week, that is around 22nd day of intrauterine life, thereby connecting the placenta with the embryo via the umbilical cord and its vessels. As pregnancy advances, the villi are more pronounced at the embryonic pole and they expand to give a bushy appearance, and this is known as the chorionic frondosome. On the other hand, villi at the ab-embryonic pole are less well developed and it is known as chorionic villi. This later degenerates and gives a smooth features around the ab-embryonic region, that is around the 12th week of intrauterine life. So villi at the embryonic pole is bushy, it's known as chorionic frondosome. Villi at the ab-embryonic is less well developed and it forms a smooth structure, later degenerates, and it is known as chorionic levi. Chorionic frondosome overlapped by Deciduea basalis has abundant lipid and glycogen, whereas the chorionic levi overlapped by Deciduea capsularis has relatively less lipid and glycogen. The villus system of the trophoblast. Chorionic frondosome overlapped by Deciduea basalis is ready to supply nutrients and oxygen to the embryo by 21st to 22nd day and heart beats as early as 22nd day of intrauterine life. Whereas the villi at the ab-embryonic pole degenerates, that is chorionic levi, which is overlapped by Deciduea capsularis. Chorionic villus biopsy is usually done around 12th to 15th week to detect any genetic disorders in the fetus. It is done under the guidance of ultrasound. As pregnancy proceeds, there is an increase in size of chorionic cavity. Deciduea capsularis is stretched and degenerates, and subsequently chorionic levi also comes in contact with Deciduea parietalis. On the opposite side of the uterus, the two of them fuse, thereby obliterating the uterine lumen. The only portion of chorion participating in the exchange is the chorionic frondosome overlapped by Deciduea basalis. Together, they make up the placenta. Coming to the structure of placenta by the 16th week. So placenta exhibits two important compartments. The fetal compartment is chorionic frondosome. The maternal compartment is Deciduea basalis. On the fetal side, the placenta is bordered by chorionic plate. On the maternal side, it is the Deciduea basalis, that is, it is bordered by the decidual plate. Between the chorionic plate and the decidual plate are the intervillous spaces filled with maternal blood, in which we have the floating villi, which are the branches of the stem villi. Fourth month or 16 weeks onwards, the deciduous septa projects into the intervillous spaces but do not reach the chorionic plate. As the result of the septa, placenta is divided into number of compartments, and these compartments are therefore known as cotyledons. Placental surface area covers 15 to 30% of internal surface of the uterine cavity. Each tertiary villus connects the chorionic plate with the decidual plate, forming the stem villi. From the stem villi, we have numerous branching system, that is the floating villi or the terminal villi, which projects into the intervillous spaces. Terminal villi form the functional units of the placenta. Each terminal villi is covered by two layers of trophoblast, inner cytotrophoblast and outer syncytial trophoblast. Inner and outer layer of trophoblast. Outer layer is cytotrophoblast, inner layer is a outer layer is syncytial trophoblast, and inner layer is cytotrophoblast. In the core, central core of villus, we find 1 to 6 fetal capillaries. We also find stromal cells. These are primitive mesenchymal cells. In addition to it, we have the phagocytic cells, reniform half-burst cells. So the terminal villi is covered by two layers of trophoblast, inner cytotrophoblast, outer syncytial trophoblast. In the central core of villus, we have 1 to 6 fetal capillaries, arteries and venous system, stromal cells are primitive mesenchymal cells, and phagocytic cells are reniform half-burst cells. In the early part, that is third month of pregnancy, about 300 we have in the early part, that is around third month of pregnancy, we have about 800 to 1000 stem villi radiating from entire chorionic wall. Later, as with the regression of chorionic living, which starts from fourth month of intrauterine life, only 60 stem villi persist in the human placenta. Maternal cotyledons are 15 to 30 in number, and each cotyledon has 2 to 4 stem villi with 2 to 4 fetal capillaries. 2 to 4 stem villi with fetal capillaries. However, placenta continues to grow throughout the pregnancy. It is considered to be matured by 34 weeks of pregnancy. Aging is a physiological phenomenon that eventually occurs in every tissue, including the placenta, with strictly limited lifespan of 40 weeks of intrauterine life. Placenta often cannot continue to deliver adequate nutrients to the fetus and increase beyond 40 weeks, and which increases with the stillborn rate. Coming to the circulation of the placenta, the cotyledons receive blood from 8 to 100 spiral arteries, which pierce the decidual plate and enter the intervillar spaces at regular intervals. Spiral arteries, which pierce the decidual plate and enter the intervillar spaces at regular intervals. 80 to 100 spiral arteries pierce the decidual plate and bathe the floating villi with oxygenated blood with high pressure. 80 to 100 spiral arteries. They bathe the floating villi. About 500 to 600 ml of maternal blood circulates through intervillar spaces per minute, and volume of intervillar spaces is 140 ml. Therefore, blood within the intervillar spaces is exchanged 4 times per minute. Placenta at term presents umbilical vein, one umbilical vein, two umbilical arteries which constitute the fetal circulation, endometrial veins and arteries which constitute the maternal circulation. Placental circulation is therefore uteroplacental circulation and fetoplacental circulation. So placental circulation is therefore starts from umbilical arteries, which are two in number, which carry deoxygenated blood from the fetus, becomes continuous with the chorionic arteries, and chorionic artery finally enter the intervillar spaces, and these deoxygenated blood is drained by the endometrial veins to the mother. Endometrial arteries from the maternal side now bathe the intervillar spaces, and this oxygenated blood is finally carried out by chorionic veins and finally by umbilical vein, which is a single vein which enters the fetus. It carries the oxygenated blood to the fetus. This constitutes the placental circulation, which includes fetal circulation and maternal circulation. Placental circulation, the fetus gets its oxygen and nutrients and returns its waste and carbohydrates, mainly from the two components of placenta. Fetal part is chorionic frondosum. The maternal part is deciduum basalis. Third month of pregnancy, the placental barrier has 4 layers. The 4 layers are endothelium of fetal capillaries with the basement membrane, the core of primary mesoderm, the basement membrane of cytotrophoblast, and the syncytial trophoblast. Fourth month onwards, only 2 layers make up the placental membrane or placental barrier. It is the endothelium of fetal capillaries and the syncytial trophoblast. These 2 layers form the true placental barrier. Since maternal blood in the intervillous spaces is separated from fetal blood by the chorionic derivative, that is syncytial trophoblast, human placenta is therefore known as hemochorial type. So placental membrane or barrier which separates the maternal blood from the fetal blood. So early part of pregnancy, that is before the 4th month of intrauterine life, the barrier consists of syncytial from outside to inside, syncytial trophoblast, cytotrophoblast, the connective tissue and the endothelium of the capillaries. Later part of pregnancy from 4th month onwards, the placental barrier consists of 2 layers, the syncytial trophoblast and the endothelium of the capillaries. Some areas of terminal villi, the syncytium fuses with the capillary wall, and this is the vasculo-syncytial membrane, and these areas are known as alpha zones, are the sites of materno-fetal exchange. The rest of the areas are non-membranous. They are the beta zones where the stromal cells and cytotrophoblast persist, which are the sole function of hormone synthesis. Placental barrier is not a true barrier as many substances pass through it freely. Normally, there is no mixing of fetal and maternal blood. However, fetal blood cells occasionally escape across microscopic defects in the placental membrane. Coming to the adult placenta or matured placenta. Macroscopic structure of the placenta has a fetal surface, a maternal surface. Full-term placenta is discoid, diameter around 15 to 25 centimeters, 3 centimeters thick and roughly about 500 to 600 mg. At birth, the placenta is torn from the uterine wall approximately 30 minutes after the birth of the child and is expelled from the uterine cavity. It presents two surfaces, fetal surface covered by chorionic plate. Maternal surface is irregular with 15 to 20 cotyledons and presents a peripheral margin. Placenta acts as a lifeline, therefore, nourishing the growing fetus and supporting its development throughout the pregnancy by its connection with the umbilical cord. Therefore, placenta is a crucial organ during pregnancy, serving as a vital link between the mother and the developing fetus. Placenta is delivered shortly after the baby is born, usually between 5 to 30 minutes after the birth of the baby. And this stage is the third stage of labor. If the baby delivered vaginally, uterus will continue to contract and expel the placenta. Retained placenta is one of the pathological feature of placental delivery, in which the failure of placental delivery occurs after the baby is born. Retained placenta happens in around 2 out of 100 births. Retained placenta, the treatment is manual removal of placenta under anesthesia. This needs to be carried out within few hours after the delivery to avoid severe hemorrhage. Coming to the placental abnormalities, these abnormalities and variations include anatomical, physiological, and abnormal implantation of the placenta that may lead to serious placento-maternal fetal effects. The diagnosis is usually based on ultrasound taken in the second or the third trimester of pregnancy. Placenta related to important variations. Lobular placenta, presence of multiple placenta or one placenta is divided into two or more parts, either completely or separated or joined by for a single baby. This type is based on the number of placenta. Biparate is two divisions, triparate is three divisions. Bilobular placenta is multiple placenta with a single fetus. It is thought to result that localized placental atrophy as a result of poor deciduation or vascularization of the part of the uterus which presents the placental theory, which leads to various variations of the placenta, biparate, triparate or bilobular. Placental centurate or accessory placenta is connected to the main placenta by fetal membranes. It is a smaller variation of bilobed placenta. Accessory placenta is developed from activated villi on the chorionic levy. Types of abnormal cord insertion. There are four types of cord insertion. Or the umbilical cord can be attached marginally, velamentous insertion, eccentric and central. Central is normal. Eccentric is also considered as a normal where the cord is inserted to the about 2 centimeters from the placental margin. It's also not a grave concern. The abnormal insertions are Bartle-Tor placenta, where the umbilical cord is inserted almost to the periphery or the margin of the placenta. This type of attachment may show slow and flow nutrients from the placenta to the fetus, causing the fetus to develop slowly. Intrauterine growth retardation is common with the Bartle-Tor placenta. A marginal cord insertion is also common in multiple births. It's known as Bartle-Tor placenta. Velamentous insertion of the umbilical cord is known as velamentous placenta. It is one of the complications of the umbilical cord as it's inserted to the membranes. The placental growth regions with a better blood and portions atrophy regions are poor blood flow. The exact cause of velamentous cord insertion is unknown. Velamentous insertions tripled by prenatal death risk. There is a high risk of hemorrhage for the fetus with velamentous cord insertion because fetal blood vessels are not protected by the Wharton's jelly. Velamentous cord insertion is often diagnosed by using ultrasound. Treatment may include close monitoring, planned delivery, often via cesarean section. Coming to the variations in size of the placenta. Large or heavy placenta, Then the normal placenta, small or lighter placenta than the normal placenta. Large and heavy placenta is quite common with maternal medical conditions such as anemia, hypertension, and diabetes. Small or lighter placenta is more concerned if the placenta is damaged after implantation. The other risk factors include smoking, drinking alcohol, and using drugs during pregnancy. Large placenta and small and lighter placenta. Pathological variations of placenta. Hematoma of placenta. Hematoma present in the placenta. Structural abnormalities of uterus or pelvic infection can lead to hematoma of the placenta. Cysts of the placenta have also been associated with maternal diabetes or rhesus Rh incompatibility. This can be associated with trisomy 13 or triploidy. In hematoma and cyst of placenta, there is always an intrauterine growth retardation of the fetus. Syphilitic placenta, abnormal large pale yellow-gray placenta. Edematous placenta, bushy, thick and pale, filled with fluid. Infected, infarcted placenta or infarction of the cotyledons of the placenta due to reduced blood supply. It can be due to the occlusion of spiral arteries by thrombosis or strangulation of placental villi. Placental insufficiency may result in fetal death. Gestational diabetes, high blood sugar levels during pregnancy can damage blood vessels and impair placental function, increasing the risk of infarction. Tumors of placenta. Placental teratomas occur due to the aberrant germ cell migration due to the embryological development. As these tumors contain pluripotent embryonic germ cells, differentiation across the cell lines can occur. Melanoma is also most common maternal malignant tumor to metastasize the placenta and the fetus. Degree of depth of invasion. Placenta accreta deeply adherent to Decidua basalis, which forms usually 75%. Placenta increta penetrates into the myometrium 15%. Placenta pericreta penetrates deeply into the uterine wall and sometimes invading the neighboring organs like urinary bladder, about 5%. Abnormal site of implantation, that is placenta previa, lower part of the uterus, closely to the internal os, and that is placenta previa, leads to serious bleeding during parturition. Painless bright red vaginal bleeding. Premature separation of the placenta is known as abruptoplacenta. Placenta separated from the uterus. It can be due to the external bleeding or internal bleeding. Painful vaginal bleeding. Bleeding is not always present because it's usually internal. Other important clinical relations is erythroblastosis fetalis and fetal hydrops. Fetal red blood cells antigens cross the placental barrier, stimulate maternal antibodies. These antibodies will attack and hemolyze the fetal cells, resulting in hemolytic disease in the newborn, which is erythroblastosis fetalis, causing severe anemia and edema, fetal hydrops, and leading to the fetal death. Coming to the important functions of the placenta. Exchange of gases, oxygen, carbon dioxide is by simple diffusion. At term, fetus extracts 20 to 30 ml of oxygen per minute. Even short term of interruption of oxygen supply is fatal to the fetus. Exchange of nutrients and electrolytes like amino acids, free fatty acids, carbohydrates, vitamins. Rapid exchange and increases as the pregnancy advances. Transmission of maternal antibodies or immunoglobulins are transmitted from the mother to the fetus from 14 weeks onwards. In this manner, fetus gains passive immunity against the various infections. First 2 months of pregnancy, syncytial trophoblasts produce human gonadotrophic hormones which maintains the corpus luteum. This is secreted by the mother in the urine in early stages of gestation, which is an indicator of pregnancy. The important functions of hormone production starts around 4th month of intrauterine life. Syncytial trophoblasts produce progesterone and maintains the pregnancy. It also produces estradiol before the end of pregnancy, which stimulates the uterine growth and development of mammary gland. Placenta also produces placental lactogen, which promotes the breast development. Placenta as an allograft with respect to the mother. Fetal part of placental derivative inherits both paternal and maternal genes. Syncytial trophoblast of chorionic villi exposed to the maternal immune cells lack major histocompatibility antigens. Multiple mechanisms appear to be in place to guard the placenta. Finally, to conclude that placenta keeps the maternal and fetal blood streams separate, thereby preventing antigen reaction.